Hi, good evening, everyone. Thank you for joining. I'm Dr. Suresh Reddy, President of National AAPI. Thank you for joining today. And the moderator is Dr. Gunjan Shukla. He'll also be speaking a little bit. We have wonderful speakers, panel of speakers, and I would like to introduce Dr. Gunjan Shukla. Dr. Gunjan Shukla is trained in electrophysiology at the Beth Israel Deaconess Medical Center / Harvard Medical School. And presently, he is the director of atrial fibrillation program at Hackensack University Medical Center. Gunjan, please take it over. Thank you.
Thank you, Suresh, and welcome everyone for this first cardiovascular virtual webinar. I want to thank President of AAPI, Dr. Suresh Reddy, and Dr. Seema Arora, Chair of Board of Trustees, for creating this very, very valuable platform to learn from fellow colleagues. A few housekeeping comments. Each lecture would be about 10 to 15 minutes, followed by Q&As. If audience has any questions, please text to one of the panelists listed on the flyer. To kick off your meeting for tonight, we have a world-renowned, phenomenal speaker that is responsible for crucial advances in the field of interventional cardiology, Dr. Deepak Bhatt. Dr. Bhatt's tremendous accomplishments and experience speak for themselves, but I'll try my best to summarize his long and illustrious career in a few sentences. After completing his undergraduate education in MIT and his medical doctorate in Master of Public Health degree in Cornell University, Dr. Bhatt went on to complete his internship at Hospital of University of Pennsylvania and Cardiovascular Training and Cleveland Clinic. Over the course of his career, Dr. Bhatt has held numerous prestigious titles and appointments, including Director of Interventional Cardiology Fellowship at Cleveland Clinic. He was recruited to be a Chief of Cardiology at VA Boston and currently serving an Executive Director of Interventional Cardiology Program at Brigham and Women's Hospital in Boston, and Professor of Medicine at Harvard Medical School. He has served as a senior investigator in TIMI study group and is a recipient of numerous awards, including Eugene Brownwell Teaching Award for Excellence in Teaching in 2017, ACC's Distinguished Mentor Award in 2018, AHA's Distinguished Scientist Award in 2019. Dr. Bhatt has authored over 1,500 research articles and served as an international PI and co-PI of countless cardiovascular clinical trials. His interest in acute coronary syndrome, preventive cardiology, peripheral and coronary intervention, and his in-depth knowledge make him the ideal candidate to present a life of medicine after COVID-19 infection and thrombogenesis. Without further ado, it is my deep honor and privilege to present to you Dr. Deepak Bhatt. Please.
Well, thank you very much for that extremely kind introduction. It's really great to be with all of you here tonight. A real pleasure and treat. And I want to first say thank you to all of you on the front lines that are taking care of patients during this COVID pandemic. Really an unprecedented time, I believe, in medicine and in life. And along those lines, let me go ahead and get started with my talk for tonight, which is titled Life in Medicine in the Era of COVID-19. So as I mentioned, it's really great to be here, and especially at AAPI. I'm a lifetime member in AAPI, so thank you for having me. These are my disclosures. None are particularly relevant to the topics I'm covering tonight, but multiple research and other relationships with various companies that manufacture drugs and devices. So, of course, everyone realizes COVID-19 is quite a tragic set of events, and that goes without saying, but is it possible that COVID-19 may be an unintended force for medical revolution in a good way? Well, this is something Dr. Wang and I posited really at the beginning of the pandemic, when we saw lots of changes occurring that we felt could actually, if made permanent, be for the better, for patients, for physicians, for healthcare systems, for all of the above. I think telemedicine is a good example of that. We've probably all become quite familiar with telemedicine, and many patients are now benefiting. And it turns out, I think, that there probably is a lot of what we do in the office that can be done via telemedicine much more efficiently, much easier for the patient. They don't need to find parking at the hospital. That's often a hassle and a source of dissatisfaction. So really, I think this is something that we have to make sure stays. And obviously it'll stay, the technologies there, even older patients are getting comfortable with Zoom and other video conferencing technology. Of course, if the reimbursement goes away or is reduced, that might make it an untenable sort of proposition, but hopefully all the different facets of telemedicine will mature. I think deregulation is something else that we've learned is important. Obviously, everything has to be a balance. Too much can be a problem, but there are lots of barriers to medical innovation and research, and there's just a lot of things that we have to do in medicine, rules and regulation, that are clearly a waste of time. Every practicing physician knows it, and we should really get rid of those and make sure they don't have to come back. You know, how is it, for example, that crossing borders now and practicing, say, going to New York and helping out there during the surge in COVID-19 could be done so much easier than the rest of the time when, you know, if you have to go to another state and get a medical license, it can be a 3 to 6 month ordeal. Really silly stuff like that should go away. I think the pandemic has taught us that we can use resources much more judiciously. That, you know, we've got to be honest, there's some stuff we're doing in medicine that's probably pretty low yield and generates costs and maybe complications, but perhaps not that much good. So we need to really be more thoughtful, I think, in the future and try to do things that are evidence-based, and where things aren't clearly evidence-based, create the basis to make decisions more rationally. And finally, I think the global collaboration that's occurred with this pandemic, how quickly information is being shared across borders is truly amazing. And in the research world, we've always been pretty good about global collaboration. Large clinical trials, for example, are great ways of collaborating with people around the world. It's one of the things I love about doing clinical trials. But the pandemic has really taken it beyond just the research world to people sharing what they know in real time as they're learning about patients with COVID. And hopefully this will continue to grow. So I see some good things coming out of this pandemic that will hopefully be lasting changes that will improve the care of patients in the United States and worldwide. As well, there's some changes in continuing medical education that this has prompted. This is an example tonight where we're doing this via Zoom. In the past, this might have been a live meeting, but think about how convenient it is for people right after they've gotten home, or perhaps even still in the office wrapping things up, can tune in now, maybe do some EKG reading on the side as you're listening to me rambling on. So it's potentially a very efficient way of learning, this idea of remote learning. And while there is a certain social element to meeting in person that is lost, on the other hand, there is an efficiency, I think, to learning for many learners. And shown here is a recent publication where we commented on how even Twitter can be used to enhance medical education. And I know there's a lot of things about Twitter that are certainly not educational, maybe even the opposite of education, but the potential, it's just like, you know, a book or the internet. There's the potential for good or bad, and it's really what we make of it. But certainly learning through electronic means such as Twitter can enhance autonomy and move learning from scheduled periods of time to on-demand to even continuous learning. So I think there's a lot of potential here. And in this recent EHJ article where we were talking about continuing medical education, Twitter, we didn't just philosophize, we did look at data. It's amazing to see how many journal clubs have sprouted up that use Twitter as the basis for a journal club. So no longer is it a journal club, say, just at my hospital, Brigham and Women's Hospital, or your hospital. It's a national or international journal club where people can join in either synchronously at the same time or even asynchronously if they're in different time zones. So truly an amazing change in education. Now, not everything's been good about COVID. Of course, there have been lots of bad consequences to patients. There's also been a lot of bad consequences to clinical trials, including non-COVID-19 clinical trials, including cardiovascular trials. I'm aware of 3 that have been terminated, and there are probably more that I'm not aware of. So there have been a lot of bad things. And I've been involved with trials that were affected by Hurricane Katrina, 9/11, war in the Ukraine. Those are all horrible. Those were very disruptive to the human and research aspects in those cases. But there was research disruptions in those cases were localized, tragic where they occurred, but it wasn't a global sort of disruption of research as is occurring with COVID-19. And in many institutions, non-COVID research initiation has been suspended or at least deprioritized Beyond that, event rates could be affected, morbidity and mortality rates increased in patients that are undergoing a COVID surge. Follow-up visits are more challenging. That's true for clinical purposes. It's also true for research purposes. Data is going to be less complete as we're trying to ascertain endpoints in these clinical trials. So there's lots of challenges that we're going to face. And this has certainly been, for cardiovascular sites that do a lot of research, very, very disruptive. Okay, let me move on now from philosophy to some real facts and figures and data. And these are data from the Mass General Brigham Healthcare System, recently published in JACC, showing what happened to hospitalizations for cardiovascular conditions during COVID-19 in our healthcare system. And what you can see in black is a line from January through March in 2019. You can see the rate of daily average cardiovascular hospitalizations there, kind of pretty much a constant rate there. But then look at what happened in blue in 2020. There's January and February, if you can see my cursor, and things are going along like normal. And then it just falls off a cliff there at the beginning of March when we had the start of our COVID surge. So these are cardiovascular hospitalizations, marked decline in the rate of hospitalization. And, you know, this is concerning because at least some proportion of those patients really should have been coming into the hospital, but instead are toughing it out with their heart failure or their acute coronary syndrome or stroke or PE or whatever it might be. So really a worrisome finding there. Were there any consequences to it? Well, you can compare January 2019, 2020 or February or March, and really there's no significant differences in the rates of mortality. But here, within just our healthcare system, limited power, we see that comparing January and February to March of 2020, a trend here towards a higher rate of mortality, almost twice as high mortality in the patients who do end up getting hospitalized for a cardiovascular condition. So a lot of patients aren't coming in, and the ones that come in seem to be in pretty bad shape. Again, maybe it's because they delayed care, maybe it's because of COVID-related issues. Hard to tease that all out, but certainly all very concerning in terms of what's going on. Now, one potential solution, this is just published in the European Heart Journal, might be to think about things that are a little bit out of the box. And, you know, maybe self-treatment or initiation at least of self-treatment in acute coronary syndromes might be a possibility. It already is done for things like heroin overdoses or hypoglycemia or anaphylaxis. Aspirin, of course, we tell people at home if they are having chest pain and they think it might be a heart attack to chew and swallow an aspirin. But in the future, maybe injectable therapies coupled with remote monitoring for acute coronary syndromes might be the future. Long way to go before it's a reality, but you know, there's already case reports of people in remote regions of the world self-administering lytics based on ECGs obtained locally. So who knows, maybe in the future. And just to share a little bit of medical history with you, Stanley Sarnoff, who you have heard of, did in fact create a pen for lidocaine for self-injection for MI in the early 70s, many of you may recall. That was based on research from the Second World War in which he developed a pen for atropine for military use in chemical warfare. So it's not a totally crazy idea if we couple advanced in-home diagnostics with initiation of therapy with injectables. But let's see where this goes in the future. At any rate, right now, what we do know is that folks that are coming in with COVID-19 often seem to have elevation in cardiovascular biomarkers. Things like troponin and BNP are frequently elevated in patients coming in with COVID-19. And as you can see here in this work from China, a clear association between patients who have higher levels of cardiac troponin and a worse outcome ultimately. So that is concerning. And as it turns out, we pulled the data from a number of different trials, and it seems like at least 20% of COVID positive patients are troponin positive. Now, a lot of these are type 2 MIs, not plaque rupture per se, but still represents myocardial damage and an association with a worse prognosis. And it does appear, as shown here, that there is an early stage of immune protection, a virus response phase, an advanced stage of hyperinflammation. And in that context, where there's a host immune response phase as well, there is acute myocardial injury that occurs. The sicker the patients, the more likely it is to occur. And it's a bit of a cycle there that is might be that the acute illness and severity of illness is leading to the troponin elevations, and the myocardial damage may in fact be making the patient's prognosis worse. So part of it is probably an epiphenomenon, part of it is probably causal. And in terms of what to do with patients that have suspected myocardial injury, and also have COVID or suspected COVID, well, you know, there's a lot of algorithms out there. We're trying to refine what to do. But I'd say for the most part, the basics stay in place. If it's a patient with an acute coronary syndrome who needs to go to the cath lab, if your healthcare system is not overwhelmed, probably that's still the right thing to do, but perhaps with a little bit more thought and testing ahead of time. That is, you might just think a little bit more strongly about getting an echo ahead of time to see if there's any evidence of myocarditis or Takotsubo's or other alternate reasons for ST segment elevation MI. Might think of CT angiography more often in some of these patients. Of course, if it's a classic ECG, great story, probably still want to go to the cath lab really quickly. Thrombolysis, some places that have been completely deluged in terms of their healthcare system have gone back to doing, but in general, I think especially if one is worried about alternative diagnoses that may not have epicardial disease or may involve inflammation of the myocardium, probably a lytic isn't really the best thing, again, unless the system is so overwhelmed that there's no choice. Beyond just the myocardial injury part, there's lots of other things that seem to be going on. Thrombosis is a big part of what's happening. Obviously, epicardial thrombosis can be an issue, microvascular thrombosis, lots of reports of strokes, including in young people, lots of reports of DVT and PE, and there are trials that are going on to see what the role of various degrees and types of anticoagulation may be. So we'll have to wait and see what those studies show. But for the time being, I would say at least treat patients that have cardiovascular disease with appropriate antiplatelet and anticoagulant therapy based on their condition. And for those that are hospitalized, be especially careful about making sure DVT prophylaxis is in place. As well, there's inflammation going on. The thrombosis and inflammation seem to be tied together as they often are. And beyond problems with the heart, problems with the lung also seem to be particularly troubling. And fortunately, it does appear that at least dexamethasone, based on the most recent data, may have a role in those with lung complications, that is requiring oxygenation or ventilation. So a little bit of progress there as well in combating inflammation, but lots of other studies ongoing. Well, with that, I'd like to thank you for your attention. Hopefully these thoughts about COVID-19 and cardiovascular disease and medicine in general were of interest. Thank you.
Thank you very much for a very, very interesting insight regarding the cardiovascular thrombogenic complications of COVID-19. While we are gathering other questions, I have one question for you, Deepak, that now these biomarkers seem to be increasing in those patients who really have a thrombogenic complications. Is there any advantage of starting anticoagulation earlier in those patients who expresses a high level of biomarkers?
It's a terrific question. I mean, I think for right now, the best thing to do is follow the guidelines as you normally would with respect to anticoagulation. I think there might be a greater role for anticoagulation in patients who are COVID positive. As I mentioned, a lot of their complications end up being thrombotic. On the other hand, anytime we're initiating potent antithrombotic therapy, especially in older patients, the ones that are most likely to die from COVID, you know, the risk of bleeding is also higher. So for right now, I would say make sure you're following the guidelines. And if it's an ACS patient, of course, they should be anticoagulated and on antiplatelet therapy. You know, if they have a DVT or PE or atrial fibrillation, anticoagulation is appropriate. But other than that, I don't know that I would necessarily step up something just because of COVID positivity, other than making absolutely sure that they're on appropriate DVT prophylaxis. Now, some hospitals have adopted algorithms of more aggressive antithrombotic therapy, but as I said, there are large randomized clinical trials going on. So in general, I would wait for those results before pulling the gun too early.
Great.
But we have a question from the audience. On the same topic, I have a comment actually. In our hospital here in Northern California, what we have noticed is there is a doubling of cardiac arrest patients coming in, and then doubling of people with strokes coming in out of the TPA window. So we can assume that's because people were holding off on the symptoms and all. But the question that came up is why is the difference? You know, why are you seeing that these hospital cases in general have come down? Is that just because the lack of stress contributing to lesser events, or is that patients were just, you know, holding off on their symptoms?
Great question. And the honest answer is we as a medical community, as a public health community, are still trying to tease out the answers. And I think right now my answer is yes to all of the above. That is, all those things are happening. There are certainly patients who are delaying care for stroke, heart attack, acute coronary syndrome, heart failure, that really should be coming in, but that they aren't because they're scared to come to the hospital. And we've got to get the message out. Don't be scared to come to the hospital. If you have a reason to come to the hospital, come to the hospital. It's safer than going to the grocery store. So we really should get that message out to our patients. And it's not just our patients, just to people out there who are potentially ill and patients. So for sure, that's part of the problem. I've seen, you know, more reports and personally seen complications of the MI that haven't really been as prevalent in a decade or two, probably since, you know, the lytic era before primary PCI, because patients are waiting to come in. Just the last weekend I was on call, I saw somebody come in with this enormous apical aneurysm. Actually, it wasn't on a weekend, it was on a Monday as an outpatient. It was an outpatient cath, actually, where it was an LV apical aneurysm because, you know, she'd had some chest pain and didn't want to come in, you know, a week or so before. So really bad stuff in terms of delays in care and seeing complications that, again, haven't been so prevalent in a while. So that's definitely part of it. Now, the other part of it, could there be something good going on? Well, possibly. I mean, I do think there's a lot to be said about pollution as a trigger. And in particular, you know, that stressful commute and pollution to work. I think that does trigger a few ACS and heart failure exacerbations and arrhythmias and so forth. So I do think that might be part of it. I mean, if you look, for example, in some cities, I'll just give Delhi as an example, the rates of air pollution have come down dramatically. And could that have an effect on less cardiovascular disease attributable to pollution? Yes, I think so. But still, of all those factors, I think ultimately we're going to see a lot of people coming in bad shape because of worsened heart failure or coronary artery disease because they were toughing it out at home. I think that'll counterbalance the reduction in things like pollution.
And we keep hearing about 3,000 to 4,000 deaths in New York City that were not reported, but did happen. And do you think that's majority of those could be myocardial infarctions and strokes, dying at home, not even coming and calling 911?
I think so, because, you know, early on I saw some, you know, kind of weird stuff. I mean, it happens, but, you know, for example, a lady that came in with an acute MI and an acute stroke, and we were trying to figure out, is she COVID positive? And at that time, it wasn't clear with the testing that she was COVID positive, but it just, I mean, of course you can have dual ischemic events like that. I've seen that before, but there were just things like that seem to be happening at greater frequency. Hard to know if it's real, it's all anecdotal, but I do think that there are COVID-related deaths that weren't attributed to COVID. So direct things like that, but also indirect ones, like I mentioned, where a patient doesn't come in because they're afraid of COVID in the hospital and catching it. So, or patients that don't get their prescriptions filled, or ones that don't have their outpatient visit because they don't know how to use Zoom. So, you know, they just sort of aren't doing the things that their doctor would otherwise tell them to do. So for a variety of different reasons, or eating poorly. We talked about less pollution because they're not driving to work in a stressful commute. But on the other hand, maybe they're at home, not exercising, eating a lot of junk food. So, you know, lots of people have described weight gain during the pandemic. So, you know, it's hard to know how this will all balance out. But my guess is, in the end, there'll be a negative toll on cardiovascular health and overall health. You know, there have even been reports of mental health among the young suffering. I mean, maybe for us on this call, we're older, we're used to, you know, disappointments in life and things not going well. But you know, I think for a young person who was looking forward to graduation or some major life milestone, you know, it's gone now. So I think there's going to be all sorts of adverse health consequences. And I think we are underestimating the physical, for that matter, mental toll of COVID-19.
I think there is no more question.
Well, there are a couple more questions here. I don't know if we have time, but somebody did ask in the question and answer box, not the chat box.
Yeah,
about.
there is a question here. Is it possible that South Asians could be at relatively high risk of COVID given high prevalence of CVD and or diabetes?
Yeah, it's a terrific question. I just a couple of days ago was on a Zoom call with two elderly people from India, a neighbor's parents-in-law who were in kind of rough shape. I think that the combination of multiple risk factors, obesity, diabetes, could really take a toll in India. I mean, as you all know, in India right now, there's a lot of problems with COVID. Probably this is scratching the tip of the iceberg. But likewise, South Asians in other parts of the world, whether in the UK or the US, I think it is conceivable they might be at higher risk, not because of being South Asian per se, but rather because of a tendency to have lots of cardiovascular risk factors. So I think that's really a great question and something we should be vigilant of in our South Asian patients, but in our patients in general. And since someone asked about South Asian patients, I guess I would say that, in general, in all our patients, South Asians included, now's the time to be really careful about assessing their cardiovascular risk. And I think, one of the best things we can do in terms of being cardiovascular type physicians is making sure that our patients already in our care are getting their risk factors managed even more aggressively than we might otherwise do. Because again, maybe they're not exercising, maybe they're eating worse than usual. And there is, of course, the threat of COVID. So trying to maintain ideal cardiovascular health is always a good idea, but even more important now, and perhaps particularly important in that at-risk South Asian in whom we know there are very high rates of coronary artery disease, oftentimes silent.
That is great. And Deepak, I want to ask a last question regarding your first slides. You mentioned about telemedicine, and we have opened up sort of Pandora's box regarding this is a new way of seeing patients on the. Do you think it is here to stay even after COVID era passes? And what are the other technologies that can develop, like getting EKGs remotely and stuff like that? Are you aware of those kind of new technologies?
Oh yeah, absolutely. I think that those things are really going to gain a foothold now. I mean, telemedicine, the technology has been there for over a decade. The real problem is, as everyone on the call knows, is lack of appropriate reimbursement for it. That's really been the greatest barrier to adoption. It's not that physicians aren't tech savvy, most are, but I think that's been the real barrier. So as long as there is a reimbursement system that is commensurate to the degree we want, I think telemedicine will be here to stay and will keep getting better. It's a very efficient way for patients. Again, they don't have to worry about the hassles, in a place like Boston, driving into the city, trying to find parking. The parking's expensive. It's a headache. By the time the patient gets to the office, their heart rate and blood pressure are up, they're having chest pain. So I think it's really very good from a patient perspective. We have to be cognizant, for patients that are socioeconomically disadvantaged, there might be some issues where we need to make sure they don't lose access. For patients that are very old, not all are necessarily going to be as tech savvy. We have to be cognizant of that and make sure that those demographics aren't left behind. But ultimately, I think these are here to stay. They will be coupled with technologies like remote monitoring, either initiated by the patient, iPhone, or remotely through other technologies. So I think all these changes are going to converge and be catalyzed by this crisis. It often takes a crisis to change, but sometimes it can be positive change. And I do think there'll be positive changes such as that coming out of COVID-19.
Great. In interest of time, thank you so much for participating in this cardiology webinar, and I thank you very much for your insights.
Great, thank you all so much, and take care, everyone. Stay safe. Keep up the great job taking care of patients.
Great, thank you. So with that, we are going to move on to our next speaker. Our next equally renowned speaker, Dr. Arvind Bimraj. Dr. Bimraj completed his MBBS at Gandhi Medical College in Hyderabad and did his MPH at Kansas University School of Medicine. He went on to complete his internal medicine residency at Drexel University, cardiology fellowship at John H. Stroger Junior Hospital of Cook County, and advanced heart failure and transplant cardiology fellowship at Cleveland Clinic. Dr. Bimraj currently serving as the intern chief, Division of Heart Failure and medical director of the Mechanical and Circulatory Support and Heart Transplant Program at Houston Methodist DeBakey Heart and Vascular Institute. He has incorporated teaching throughout his career as an assistant professor of medicine at Houston Methodist Hospital, Weill Cornell Medical College, and Texas A&M University College of Medicine. His awards include Craig and Pratt Award for Faculty Teaching Excellence and Houston Methodist Leading Medicine Cardiovascular Disease Faculty Teaching Award. His long list of publications and the variety of cardiovascular clinical trials under his belt shows his commitment to research. I am really honored to present Dr. Arvind Bimraj to give us insight into management of cardiogenic shock in the patients with COVID-19 patient. Arvind.
Thank you very much for the kind introduction, Gunjan, and it's a pleasure and honor to be a part of this program on a very important topic overall, and it's not easy to follow world-renowned leaders who spoke before me, but I'll do my best. Let me share my screen and then make sure that. So the next, hopefully 10 minutes, will focus on aspects of cardiogenic shock in patients on COVID-19 infection. If you look at the impact of the virus on the heart, there are various ways it can affect, and a few were addressed earlier by Dr. Butt on ACS and myocardial injury, thromboembolism. But essentially, the impact by the myocardial, either direct or indirect effects, can cause cardiogenic shock. Now, people with pre-existing heart failure have a higher risk in general, but you can also have de novo myocardial injury as represented in this figure. And of course, ACS by itself can cause cardiogenic shock. With that in mind, I want to guide the audience to a review of in general cardiogenic shock, because it itself is a complex syndrome. In the DeBakey Cardiovascular Journal done recently, I'm biased because I was a guest editor, but I had the privilege of putting together a lot of good authors across the nation. So it's a good read available online for everybody that I would guide to, because we probably can't cover every concept of cardiogenic shock today. But the basics of cardiogenic shock, if you think about it as a problem of perfusion of the body, one of the acknowledgements that we have to make is we pay a lot of attention to renal function, liver function, and abnormalities of the perfusion of the body because of lack of perfusion is important, especially in patients with COVID. You have to differentiate whether this is a perfusion problem or if this is a problem of COVID infection by itself, because they can have abnormalities with LFT. But in shock, the heart gets forgotten most of the times because you're so focused on renal function that the stress on the heart, the performance of the heart, and afterload and preload are relevant for us to keep in mind. And that's where the shift has been from pressors and inotropes to more of mechanical support. So it's a complex syndrome which needs every kind of a minute observation on these patients. Hemodynamic assessments is quite relevant. And I put this slide up that we've hated the SWAN for years together because of controversies, but currently there's enough data to suggest when used appropriately in this slide deck on a database from CVAD, the Impella registries, showing that if you use the information appropriately, we can improve outcomes in these patients. And all the old data about Swan-Ganz catheters, which I have here dating from the sepsis trial to ESCAPE trial, they really don't address the patients who have cardiogenic shock, and it's important to distinguish that. Now, of course, doing procedures with PPE becomes complicated. There are times where you can use surrogate markers for hemodynamics like CVP from central line, central venous saturation instead of mixed venous saturation, and echo for cardiac index and filling pressures. But I use caution because in this syndrome, if someone's getting worse, if you're doing all the PPE-based interventions, a Swan-Ganz catheter is not a big deal. Mechanical support in the context of any cardiogenic shock, and specifically for COVID, is relevant to acknowledge that there's a plethora of devices that are available, ranging from the simple intra-aortic balloon pump, which is a counter pulsation device, Impella, which is a trans-aortic device that goes across the aortic valve that you notice in the cartoon and pumps blood out. And then the tandem heart, which goes transeptal into the left atrium and pulls out blood, oxygenated blood. And then ECMO, which pulls out deoxygenated blood, oxygenates it, and pumps back into the aorta. Intra-aortic balloon pump can be placed bedside very easily. ECMO also can be placed bedside very easily. Impella and tandem do need the cath lab, even though there's been some reports of putting in an Impella bedside. And those are logistics that are practical we need to be mindful of. So just a quick example of a case. If you look at this is a 49-year-old patient who presented, has no history of heart disease, chest pain and shortness of breath. And you see that EKG is remarkably abnormal with a lot of ST elevations. Of course, we take them to the cath lab to be sure, but it's quite obvious that this is diffuse ST elevations, and this gentleman had normal coronary arteries. So what happens in COVID? In the de novo infection of myocarditis, the possibility right now, and there's a lot of hypotheses and case examples, is one is immune injury. In one of the studies, you can see the myocyte destructions in this slide, in the H&E of the biopsy here, autopsy actually. And then the one on the right was a study which showed direct invasion of the viruses in the myocardium, and this was a biopsy study. So both are possibilities, which is not uncommon compared to any viral myocarditis that we've seen before. As pointed out before, the troponin injury is classic in this Wuhan study, and of course, high troponins are always bad. This is an example of an echocardiogram cross-section, and you see that the heart's barely moving and squeezing. This is a short axis for those who don't look at echoes normally, and this is the LV and RV. In myocarditis, in any kind of a viral myocarditis, typically it's a bi-V involvement, and that's important to remember. When you talk about mechanical support for in COVID infection, I want to distinguish for individuals that VV ECMO is the most commonly used. Technically, it's not a cardiac mechanical support when we talk about ECMO. VA ECMOs are not that commonly used only because by the time somebody needs VA ECMO, they're quite sick. An Impella device along with VV or VA, and of course a balloon pump. There's not much data about these percutaneous devices yet where people are collecting it. And you look at the ELSO registry, as I pointed out, majority are VV ECMO here for oxygenation, which is technically not mechanical support, but the use of VA ECMO appropriately is not very much. Because ECMO is talked about whenever when we discuss COVID. The same thing is reflected in the ELSO registry that I have pointed out here. Only 3% are cardiac support. Majority of the ECMO support is really due to lung injury. And just to clarify for those who don't deal with ECMOs, a VV, venous ECMO, there are different ways of connecting the circuits, but essentially you're pulling blood out of the body through the right side, oxygenating it, and just putting it back. It can be different drainages through the groin, through centrally. No matter how you do it, the concept is venous to venous return. When you do a VA ECMO in any myocarditis, you can have various options again. Peripheral cannulation, where the venous side is, the blood is pulled out of the venous side. It's not just oxygenated, but it's also pumped back into the arterial side, hence the VA ECMO. Various cannulations, again, it can be central, peripheral, through the neck, but the concept is that you're taking over the heart and the lung, which most of the times is the case for a biventricular support system in an acute setting. One of the concepts of cardiogenic shock, when you talk about a VA ECMO that's emerged and it's relevant for any myocarditis, is the fact that when you put in an ECMO cannulation, peripherally especially, for example, in this figure on the left, you're pumping blood into the iliac and pumping blood into the arterial circulation with a lot of pressure. So a heart which is already beat up will have to face a lot of afterload. That's the reason why it is recommended to decompress. So whether you use an Impella called as ECPella, where you have the ECMO circuit and an Impella, or you use a balloon pump, the idea is that you can't just put in an ECMO the body might be saved, but the heart still struggles because most of these patients, we are aiming for recovery. And this is a simulation of a pressure volume loop as an example. If you notice, once you put in an ECMO, you see the curve become very narrow, which is a very high afterload. And as the afterload increases, the LV EDP, the end diastolic pressure, if you notice the green to the red corner, it's increased. This is what causes lung injury and continues the heart to struggle. And this is an example of somebody who has an ECMO put in, and the lungs are not perfect, but you see the arterial line here that you're pulsatile, but there are times that you lose pulsatility because the heart's unable to even pump blood. And this is a TEE example where you see the echo, all this haziness is clot. So if you do not unload the heart with any of the devices and you're not mindful of this, you will definitely clot the heart. And sometimes if it's not picked up early enough, this was an example of somebody where inotropes helped, but of course it went up to the brain and you can cause adverse neurological outcomes. To summarize, this is an example of a protocol that we've developed internally for cardiogenic shock for COVID patients. And while there's no strong evidence how to do this, I think it's important for each institution to sit down and plan it ahead of time. We have developed some relative contraindications for mechanical support because no matter what you do, if somebody has multi-organ failure because of COVID, putting in an ECMO or MCS might not lead to a good outcome, but it's probably relevant not to have journal clubs in the middle of the night than have this protocol upfront so you can know what to do and not deprive patients of the care. So in summary, it's very important to identify COVID patients with cardiogenic shock and treat them appropriately. In general, cardiogenic shock needs a multidisciplinary team approach, and now add COVID where there's so much unknown. I think it's most important to have that team approach where people can sit and discuss what to do. It is relevant to make sure that we're not missing because of missing things or not doing interventions that are recommended because of lack of PPE, but that's a reality we have to plan for upfront. And on the other hand, beware of not looking at everything as COVID, because patients with MI, if you think it's COVID myocarditis, things can get missed. And this was an example that we had published as a case that when zebras are everywhere, because myocarditis for the heart was zebras before, now they're everywhere in COVID, don't forget the horses as such. With that, I'll wrap up. This is the Texas Medical Center, and I'm proud to be in the legacy of Dr. DeBakey's institution. Thank you.
A great talk, Arvind. There was very good insight about the cardiogenic shock for COVID-19 patient. While we are accumulating questions, I'm just going to ask you one question regarding direct invasion of a virus into myocardium. Is that, or do you know of any patients who actually had a tremendous cardiomyopathy and may have been considered for a cardiac transplant with this?
So I think when you look at current COVID crisis and the need for ECMO, as you notice, it's only 3% of those individuals who are even getting an ECMO. Majority of them with cardiac involvement either don't make it because they're too sick or they've recovered. I don't think we've seen any case where you've reached a point of needing a transplant yet. I know we're going to talk about the lung transplant in this patient later on, but we have not heard of any reports across where you've needed a heart transplant for a COVID myocarditis yet. And it's going to be a tough proposition to be able to do that. I'm looking forward to learn about the lung transplant that happened, but from the heart, we've not.
Thank you.
For the ECMO, I'm presuming VA ECMO is the predominant variant, right, for this COVID lung involvement?
I'm sorry, say that again, Sujit?
The VA ECMO is the predominant format. Is that right?
So currently the predominant support for the COVID patients has been VV ECMO because of the lung injury. So venous to venous, just oxygenation support. And when you have, if you support the lungs for a while, the hope is that they recuperate and recover. Once people end up, the problem with VA ECMO is the availability of VA ECMO across is not that high. Second, when you have availability, in general, mortality after VA ECMO is very high. And when you add that to COVID patients who are in multi-organ failure, and we've had a few patients where we debated and ended up not doing a VA ECMO because their hemodynamics support that the heart is not perfect, but their multi-organ failure is disproportionate to cardiogenic shock, which tells us that it's more of a viral problem. So even if you put them on a VA ECMO, they won't survive.
Gotcha. There is one question from the audience. I don't know whether you would be in the know of the information. What percentage of deaths from the people from Indian subcontinent, if they acquire COVID-19, had mortality?
Yeah, I don't know if we have the specific mortality rates from the Indian subcontinent. At least I'm not aware of. In general, the data that I had for ECMO utilization is available for the Indian subcontinent, but I don't think there's specific outcomes data that I'm aware of, especially cardiac related.
Right. Great, thank you. So there's one more question that just came in. When do you decide to stop VV ECMO in these COVID-19 patients? Like, what's the weaning criteria?
Yes, so typically in general, when we use VV ECMO, you go by the PF ratios and lung optimization, and it rests the lungs with less of the ventilator support. And over a period of time, most of the times you end up starting with a groin ECMO, which oxygenates better. But if you need to leave it longer, you can switch it to the neck with a dual lumen catheter and leave it on until your PF ratio gets to a point where you're able to wean them off of the ECMO. And I think it's the combination of the ventilator and the oxygenation from the ECMO that you'll have to tailor.
Okay, well, thank you very much for Dr. Bhimraj for a very good presentation about the cardiogenic shock in COVID-19 patients. In interest of time, the next panelist, I was gonna speak about a QT prolongation with the risk of hydroxychloroquine, and it is a pretty well described topic, and I think I'm gonna go very quickly because we have other renowned speakers are waiting. Get my screen up. Everybody can see my screen? Okay.
Now we can see.
Okay, great. So just a brief overview. I'm not gonna take a very long time on this one. It was in 1856, the first case was described for the long QT syndrome by Meissner in Leipzig. The patient was a girl who was deaf, and she was yelled by her teacher, and she had a death, and her brother has a similar event. In 1957, ultimately after ECG, Dr. Jarvel Lang-Nielsen first described the QT prolongation. In 1963, Romano Ward syndrome. Dr. Romano and Dr. Ward, there were different doctors, and they described the long QT syndrome. And then it was a registry of the long QT syndrome. Everybody knows about the cardiac action potential And there is two particular areas where the long QT syndrome happens. Repolarization happens at the red arrow where the two potassium channels, IKR and IKS. If you have a defect in the channel, your QT can prolong and it increases the action potential. Or you can have an early portion where the sodium and calcium channel can also cause the QT prolongation. There are various syndrome has been described. So how hydroxychloroquine fits in this area? Usually the drug-induced QT prolongation usually happens in the people who have a IKR and IKS channelopathy. And these channels are maybe partially affected and which can be expressed when the drug is introduced. These are the most common long QT syndromes, and the problem with the long QT syndrome is the torsade. Basically, you have a dispersion of the repolarization. So myocardial cell, which is called an M cell, which is the middle of the myocardium, they get a longer QT prolongation compared to epicardial and endocardial cells. And that causes a dispersion of the repolarization, and that causes a torsade de Pointes. And this is the end result, which could be deadly in some of the patients. And that's why these drugs are sometimes dangerous. So measuring the long QT, usually you can see where the T wave touches the baseline. That's where we measure the QT interval. People sometimes has a lot of questions, but that's sort of a way. The most common formula for long QT syndrome is Bezet's formula. But there are various other formulas are described, which is less very well used. So this is the just overview. The QT in a up to 15 years greater than anything greater than 460 millisecond would be called a prolonged QT interval. In adult male greater than 450 millisecond, and adult female greater than 470 millisecond is called prolonged QT. So, we all know the hydroxychloroquine and chloroquine can cause long QT syndrome. I'm sorry for going pretty fast because I want to catch up with the time, but I'll briefly review some important trials and just to say that we shouldn't be using these kind of drugs unnecessarily without any beneficial effect. This is a recovery trial, which is from UK, 1,542 patients randomized to hydroxychloroquine. They were compared with the other 3,000 patients. And if you see that there is no evidence of beneficial effect noted with the hydroxychloroquine administration. This is a busy slide, but I highlighted the areas you should concentrate on. Hydroxychloroquine, very high dose versus standard of care treatment. And 28 days, there was no effect of negative conversion rate from virus or alleviating any symptom compared to standard of care treatment in this trial. This is another trial, which is a Brazilian phase 2B clinical trial, and that showed two groups of chloroquine, high dose chloroquine and a low dose chloroquine in the COVID-19 patients. And if you look at the high dose chloroquine, there are very high mortality rate, and this trial was prematurely terminated. And the last but not the least, the US VA trial, and they compared the people with the hydroxychloroquine and hydroxychloroquine plus azithromycin and no hydroxychloroquine group. And basically where they compared, the death rate was higher in hydroxychloroquine alone group. And basically the conclusion of this trial was increased overall mortality was identified with the hydroxychloroquine. So this topic has been discussed a lot, and therefore I went very fast. And if anybody has a questions, they can ask in the last session. I'm gonna introduce our next speaker in the meantime, and please hold if you have any question for me for now. This would be a perfect segue to go to our next speaker, which is Dr. Ankit Bharat, who is a very well-known surgeon, and Dr. Anil Tibrewal is gonna introduce him, who knows him very well. Anil?
Thank you, Gunjan. It's my honor to introduce Dr. Ankit Bharat, who is a friend and from my alma mater, and who has been national and international achievements and reputation in the USA. He's currently serving as Chief of Thoracic Surgery, Harold and Magnet Research Professor of Surgery, Director of Lung Transplant and Respiratory ECMO at Northwestern University Hospital, Chicago. Dr. Bharat graduated from my alma mater, Christian Medical College, Balad. He did his postdoctoral research fellowship, residency, and fellowship at the Washington State University Hospital in St. Louis. He did his clinical fellowship at Memorial Sloan Kettering in New York and MD Anderson Cancer Center in Houston. Subsequently, he moved to Northwestern University Hospital, Chicago, where he's serving as the Chief of Thoracic Surgery. He's program chair of scores of professional organizations and research organizations and editorial board of national and international level. He received plethora of grants, awards, and has hundreds of publications, which speaks for his commitment to research. Not only this, he has been first surgeon in USA to perform many surgical procedures, which includes first robotic lung volume reduction surgery, first ECMO as an alternative to mechanical ventilation, first lung reduction surgery under regional anesthesia, and most importantly, recently, as we all know, he's the surgeon who performed first double lung transplant surgery in USA, which earned him applause from millions of his fans across the world. Without further ado, I invite Dr. Bharat, please.
Well, thank you, and good afternoon or good evening, depending on the time zone. I was just trying to share my screen here. Are you able to see this or not really?
We're able to see you, but not your screen.
Do you want to share? Do you click the share screen button?
Yeah, I actually don't see that here on the Zoom, on the main. Bottom. On the bottom, I have chat, raise hand, and Q&A, but I just don't see a share option here for some reason.
Yes. Can you maybe hover with your mouse over the bottom end, see some may show up?
Vijaya, is he added as a panelist for this?
Yeah, he's the panelist.
Yeah, because I'm not able to share the screen. I don't have mute.
Can you quickly email that in a PDF format, Dr. Bharat? I can share my screen.
Yeah, it just had a bunch of videos. That's the only thing.
Gotcha.
I had a. It's kind of strange because I'm speaking on my phone, but the video is on the screen where I have my desktop. So I see the shared content on my phone, but not on the computer.
If you can join to your computer, maybe you can see them.
Yeah, that's what I.
Are you on your cell phone or?
Yeah, I'm on my cell phone and also on my computer, but on the computer, it doesn't allow me to share the content. Let me come off 1 second. Let me try something else.
Dr. Bharat, you joined too. I added you to the second one profile also.
Okay.
Can you try now, please?
Say that again. Oh yeah, now share screen. Okay, good.
Yeah, we can see your screen now.
Okay. Can you see it now?
Yes.
All right. Well, thank you for asking me to present this case. There's still a lot of work that we're doing as far as this case is concerned, but I thought I'll share some of the highlights of this case and, the thought process behind why we offer transplant here and some of the practical problems that we faced. We plan to publish this, and then also, some of the lessons that we learned during the transplant process, both from the medical standpoint, but also from the surgical standpoint. We're also in the process of doing some intensive analysis of the explanted lung, hoping that it'll give us some ideas, some clues about, some of the failures of immune and epithelial repair mechanisms that may, lead to this kind of problem in some patients. Now, the way it all started was, I'm at Northwestern, and thank you for that introduction. I'm at Northwestern, and we in Chicago got hit quite hard, like many other cities. And Northwestern, we had done a lot of preparation, and ever since we saw the first patient, we were thinking, or anticipating some patients who may end up being on the ventilator, and we may not be able to wean them off the ventilator. We are a relatively large center for ARDS in general in the region, and we take care of a lot of patients who, suffer from influenza. So we thought, this may end up, putting us in the same situation where we may not be able to wean one of the patients. So in preparation for this, we had actually instituted a warm autopsy program, and with some of the patients, who expired, we would perform a warm autopsy within 1 hour of their death and understand some of the intrathoracic changes that have occurred in these patients. And then we work closely with our other, PIs in the lab, as well as the pathologist, to understand this. So we were thinking, this is going to be, something that we are going to have to offer these patients. And in fact, in March, we had a patient, and we, where we thought transplant would have been a save, but, that individual, after about 2 months of waiting, he developed a very profound secondary bacterial infection and ultimately died before we could get him to the transplant. So, we've seen some deaths, and especially, what we found is, patients who are, going into their third month, more like, 6 to 8 weeks, and especially if they go into their third month and they have shown no signs of lung recovery, they're at very high risk of dying from other bacterial infections. And that, some of those observations help us make a decision here. So, this is a 28-year-old female with very healthy, if you saw her pictures, you would not think she would ever be in this situation, but she had, she had moved from North Carolina to Chicago because of her significant other, and she was really a very functional person, very lively individual. And she came to us in April, and she had some of the typical symptoms of fevers and cough. She came to us after about 4 days of symptoms and was tested positive for COVID, got intubated, and within a few days, the lung injury was so severe that we had to put her on venous ECMO. And I want to thank the prior speaker for going into the basics of venous ECMO. It makes sort of my talk a little bit easier. So she was placed on venous ECMO. We typically do this at the bedside because most of these patients are quite sick to be transported to the operating room. So she had 2 cannulas, call it the bicaval cannulation for venous ECMO. And she remained on that venous ECMO with no signs of lung recovery. She started to get some secondary bacterial infections and a necrotic cavity in the left lower lobe with serratia that was driving her sepsis. And then ultimately she developed a right pneumothorax, in which had actually a chest tube placed. Unfortunately, as we later on learned, that she also had significant RV dysfunction that led to congestive hepatitis, and her liver was quite large. So as the chest tube was placed in the middle of the night, it scraped through the liver, and that led to liver laceration and an emergent XLAP. Anyway, so after that, she recovered somewhat. But her lungs showed no signs of recovery at about 6 weeks from the intubation, and she was just getting to the point where she reminded us of the first patient I mentioned to you, who actually ended up dying from pretty severe sepsis. at that point. So we had a serious discussion with her family about the transplant. And given that she was so young, we wanted to actually offer her all treatment options. And, she had cleared her COVID by that time based on the PCR test. So she underwent bilateral lung transplant. We typically use veno-arterial ECMO, not the full bypass machine. It just helps us with the bleeding. And in her case, it was particularly important because the thorax chest cavity was very hostile because of all the inflammation. So post-transplant, she needed ECMO for about 7 days and then vent for 12 days. She's doing really well right now, and hopefully we'll go to rehab in a few days. This is, I've just put some x-rays for her, of her and showing her progression. So this is at the time of her presentation to our hospital, day 1. Day 7, you can start to see that, she presented with a left-sided predominant process, which is a little bit unusual. What we've seen is a more symmetrical involvement, but certainly asymmetrical involvement is seen, and it certainly seemed to be the case in this patient. So here you see, progression of the infiltration to the right side, and then by day 11, she had near complete whiteout of both the lungs, and we had to place her on ECMO. You can see the neck cannula here. The groin cannula was a little bit low. We advanced it after the initial placement. Here on day 14, she's starting to show a little worsening effusion on the right side. And this is on day 21. You can see a necrotic cavity in the left lower lobe with pan-resistant serratia. And this is just prior to the transplant. You can see, that her left lung had developed quite a bit of necrosis with multiple cavitations. The right side is nearly completely opacified. And really, she was completely dependent on ECMO. We did try to put her on dual lumen cannula in an attempt to further, boost her oxygen status and wake her up, but her right IJ and subclavian veins were completely clotted off, so that was not an option for her. So this is briefly what she received in terms of treatment. She was on the mechanical ventilation. We use high PEEP strategy, which is guided by esophageal balloon manometry to measure transpleural pressures. And then she had multiple rounds of proning, and she failed ultimately, requiring ECMO. And then in terms of medical treatment, she had received all the standard things with hydroxychloroquine, remdesivir, convalescent plasma, and cerulumab on a clinical trial. And this is just a summary of what I just mentioned to you, just to show you how sick she was. She was intubated on day 1. ECMO was instituted within a week, and within 3 weeks, she started to develop that necrotic lung cavity with serratia. And ultimately, at the time of operating room, we could not put a swan in her because of the right IJ and subclavian issues, and the fact that she had 2 cannulas in her left IJ and the femoral vein. But at the time of surgery, we measured her pressures, and they were suprasystemic, and the right heart had severe dysfunction with a wide open TR, tricuspid regurgitation, and so this was obviously in retrospect. But prior to surgery, prior to this transplant, she was starting to develop an AKI, and her urine output was getting reduced quite rapidly. I mentioned a liver laceration, which only made the problem worse. And prior to transplant, she was on 2 pressors with some vasodilatory shock. I will mention that she had negative PCR on at least 4 occasions prior to the surgery, and this was from the lung lavage fluid. These are just 2 pictures that I posted. Intra-op pictures, you can see this is the left lung implanted, and here you have the right lung, which we are about to start. As I mentioned, we use veno-arterial ECMO for this. And now she did have, the neck and the groin cannulas, so the femoral venous and the neck IJ we used for the venous drainage. So we didn't have to put an atrial cannula here, just had to use the aortic cannula. And this is post-transplant. You can see both the lungs. There are these staple lines because she had a a small chest cavity, and this was taken urgently from a taller donor, and we had to shave. We typically shave the lungs to so that it can fit in the chest cavity and not completely tamper out. And this white thing is just a bovine pericardium that we use to reconstruct the anterior pericardium since that's open. Histology showed a pretty nasty looking lungs. There was really no functional alveolar tissue left. This is the left and right respectively. And you can see, these, the lungs had developed these, these little cavities all throughout. And, as what we found was, these lungs actually developed pretty significant hemorrhage in the lungs, along with some microthrombi, and that leads to pretty significant necrosis of the lungs, or that's what the hypothesis is, leading to these necrotic cavities. This is consistent with the other warm autopsies that we've performed so far, and this is just a representative slide of one of the warm autopsy with a lot of hemorrhage and a lot of fibrin deposition and really no identifiable alveolar tissue. This is her on day 10. She was off the ventilator. She was on trach collar. You can see still she's quite weak. At day 10, we're working with her with our physical therapy staff, and this is her now off oxygen, off the tracheostomy, just getting some physical therapy, hoping that in the next few days she'll get discharged. She's going to get a swallow study tomorrow to see if she's strong enough to eat, and then this Dobhoff tube, which is a nasojejunal tube, will come out. So I just wanted to, this again, as I said, it's a very high level kind of case presentation. Like I said, we're doing a lot of extra work, trying to understand when to offer these patients lung transplant, who's the right patient, how do you determine the COVID status, how do you get consent. There are a lot of medical and ethical problems. We've a lot of centers have reached out to us, and one of the big problems that they're facing is the medical deconditioning of these patients, because most of these are quite sedated and in a lot of cases, being paralyzed for a number of weeks prior to transplant being considered. So we are learning that there are actually a lot of patients stuck in the same situation who actually end up clearing the COVID, but they cannot be in the vent. And the other thing that we are following and we, have observed is that even a number of patients who end up coming off the ventilator and they go home, they are requiring quite a bit of oxygen, and whether this oxygen need will go away as the lungs recover, or the lung injury is going to progress to the point that they're going to need transplant in the future. That's yet to be determined, but something that we need to look into. But hopefully we'll have all those answers. We're also looking at when to offer this, as I mentioned, so we are trying to look at at what point the mortality in these patients goes so high that you need to start thinking about transplant to really balance the medical deconditioning and the risk of death with transplant, because certainly you don't want to offer transplant too early in the process, because majority of the patients certainly get better. At least that's been our experience. In the recent paper that came out of our center, we only have found a 15% mortality in patients who go on the mechanical ventilation. So clearly, most patients get through it, so you don't want to offer it too early, but then we also have lost a number of patients by waiting too long. So something that further needs to be studied, and hopefully we'll be able to offer it in the select patients and the right patients. So thank you very much.
Thank you very much, Dr. Bharat, for such a stellar achievement at such a young age. Congratulations for your first double lung transplant for the COVID-19 patients, and essentially gave a new life to a young girl, which is very admirable, and I'm sure that you're feeling very proud and fulfilled. In interest of time, we're gonna do major question answer at the end. I hope you can hang out for some time. But if you can just summarize in 2 minutes or maybe 1 or 2 minutes before the next speaker starts. I know lung transplant is pretty big operation, which is successful at this time. But if you look at the future of this young girl, what is the future of year 1, year 2, or year 5 looks like for this girl?
Yeah, so it's hard to give individual predictions per patient, right? So if you look at all comers, 90% plus patients actually are alive by year 1. And now she was on ECMO and she was quite deconditioned, so that survival would be a little bit less, but I mean overall, but she's otherwise, young and healthy, 28, so I anticipate her having, over 90% chance of being, alive at 1 year. Also, when we look at patients who are alive at 1 year post lung transplant, they're quite independent, they're oxygen independent, and they're able to do all their day-to-day work. The 5-year outcomes are about 50 to 55% of the entire cohort. But again, if you take the younger patients, it's it's a little bit better. And in general, if you talk about, someone asked me how long will a double lung, 2 lungs last, the median is about 9 years, so compared to hearts, which is about 10 years. But she would be a candidate if she were to develop chronic rejection down the road. She would be a candidate for retransplant.
Great. Well, thank you so much, and please hang on for the question at the end. But in the meantime, I want to go to the next speaker because of an interest of time. Our next speaker, Dr. Samuel Asirvatham, is a world-renowned electrophysiologist and a career-long teacher at Mayo Clinic campus in Rochester, Minnesota. To briefly summarize, after completing his medical school at Christian Medical College, Bangalore, India, he completed his internship at Columbia Medical Center, followed by residency and chief residency at University of Wisconsin. He completed his clinical cardiology and electrophysiology training at Oklahoma. Dr. Asirvatham is currently a professor of medicine in the Division of Cardiovascular Disease and a professor of pediatrics in the Division of Pediatric Cardiology and Adolescent Medicine at Mayo Clinic. He is also a program director of Clinical Cardiac Electrophysiology Fellowship and director of strategic collaboration for the Center for Innovation at Mayo Clinic. Dr. Asirvatham's key insights into various research areas, including neurocardiogenic syncope, central nervous system disorders, stroke, thromboembolic complication of atrial fibrillation, has been a tremendous service to electrophysiology community. His deep commitment to teaching is unparalleled. I personally watched Dr. Asirvatham lectures for my board exams, so I can assure our viewers that he is the absolute best person to teach us about electrophysiology complication of COVID-19 patients. And it is my true pleasure to introduce Dr. Samuel Asirvatham. Thank you, Dr. Asirvatham.
Thank you. Thank you very much, Dr. Shukla. So let me. So this is going to be a quick overview. And let me get this. Oops. Let me just get back to my screen here.
We can see your slides, Dr. Asirvatham.
Yeah, for some reason I lost it. Okay, I got it back now. Okay, so quick overview, just looking at arrhythmia and COVID-19. So I'll do a brief case presentation, one of the early cases that I saw here at the beginning of the pandemic, and try to focus something about insights. What is it that's producing the arrhythmia? Is it just myocarditis? Is it direct viral involvement or something else? So there is a spectrum, and it's well recognized. Every center that has reported about COVID-19 outcomes, cardiac outcomes, has talked about arrhythmias. Some are benign, some are clearly life-threatening. There's been a spectrum of bradyarrhythmias, tachyarrhythmias, and this is a patient, probably one of the first COVID-19 patients we took care of here in Mayo Rochester. And the predominant presentation in this patient was tachyarrhythmias, ventricular tachycardia, very difficult to manage, and took a lot of effort to finally get things under control. When she presented with fairly mild symptoms, some dyspnea, some cough, had a history of exposure. We're testing her, and had a resting electrocardiogram when she came in that was abnormal, but really didn't portend what we were going to see unravel in a very quick time. First changes we noticed was intraventricular conduction delay. Generally a sign something is happening to the myocardium. The delay was nonspecific, and it was affecting what appeared to be both sides of the ventricles. And then she went into a combination of sinus tachycardia, ectopic beats, multi-direction PVCs, and very quickly after that was in VT. And the VT was incessant and became really the predominant characteristic of her hospitalization. Now, if we look at some of the early studies, and when we focus on mortality and cardiac complications, the things that were common to her, this patient, and the general reports were sickest patients have evidence of cardiac injury, troponin, other myocardial markers of injury, and arrhythmia. And indeed, the patients who have pre-existing cardiovascular disease as a manifestation of their COVID-19 hospitalization, in addition to lung disease, who have elevated troponins, are the ones who get arrhythmia and are the ones who have mortality, sometimes related to the arrhythmia. And just borrowing on some cases, early reported cases, to give some insights as to why the arrhythmia might occur, we know that the myocardial dysfunction is a combination of inflammation and possibly features that we're used to seeing in patients who have direct viral myocarditis. And as part of their syndrome, they do tend to get evidence of myocardial slowing, intraventricular conduction delay, and the worst case of when there's slow conduction in the heart, setting up of reentrant ventricular tachycardias. Reentrant ventricular tachycardias, when there is slow conduction, are very hard to handle because any PVC, any kind of stressor can set off the VT, and it can be incessant or recurrent. Early days, we also had reports which have since been validated of bradycardia. So clearly three themes have evolved. One is ventricular tachycardia, second is just sinus tachycardia, and the third is conduction blocks, ventricular level, AV level, or intraatrial level. So we look through arrhythmias as in the context of ECG findings, background of acute coronary-like ECG findings, pericarditis-like findings. We have these unstable electrocardiograms, wide QRS, and transition to VTs or conduction blocks. What's the reason for this? Well, if we look at other myocarditis that we know fairly well for decades that present with arrhythmias, the two that come to mind are Coxsackie-like myocarditis, which tends to produce conduction slowing and tends to produce ventricular tachycardia, and parvoviral myocarditis, which involves mainly the subendothelial layers, which produces Purkinje malfunction, conduction blocks at the infrahisian level. Thus, the dictum when we look at biopsy in acute myocarditis, the yield for biopsy for a virus is highest when there is infrahisian conduction disease. It tells us that there is subendothelial involvement, which you might be able to see on a biopsy. Now, if we focus on the spectrum and we have to think a little bit pathophysiologically, why these changes? We actually have decades ago an animal model for coronavirus that had been studied. This was the rabbit coronavirus model in the 1950s, 60s, early 70s. And what was observed is ECG changes. The most common ECG changes in this rabbit model was sinus tachycardia. This is something also seen clinically during and after recovery with inappropriate prolonged effects of sinus tachycardia. Now, the implications for humans from this model is there is, with coronaviral involvement, quite significant autonomic modeling or change in the autonomic tone that occurs, much like we see in the syndrome of inappropriate sinus tachycardia. In addition, there is irritation at the ventricular level, ectopy and tachycardia, at the AV nodal level to produce block, and at the subendothelial level to produce Purkinje-related block like alternating bundle branch block. And this is borne out with histological changes after coronavirus infection in the rabbit, where we see infiltration and both direct demonstration of virus as well as inflammation in the compact AV node, intraventricular septum, and at the atrioventricular junctions. You know, one interesting aside in this patient is when we saw that initial ECG, one of the challenges is trying to predict, especially when you get a transmitted ECG or Apple Watch monitor, who are the people who have ventricular dysfunction. And it's something that can be hard to do with a single electrocardiogram. In this patient, we had run through something that's routine in all of our ECGs, an artificial intelligence algorithm that actually correctly picked up a very high likelihood of severe myocardial dysfunction. Another role or insight that has come from artificial intelligence is natural language processing algorithms for the genome of the virus and comparing it with existing structures in the body. And one of the key differences for SARS-CoV-2 compared to even other coronaviruses and other SARS viruses is a small sequence near its binding site, also close to its cleavage site. And this sequence is actually shows homology, very close similarity to the human sodium channel. And specifically the human sodium channel, which is found in the pulmonary epithelium and also found in some structures like vascular structures and in the compact AV node, especially in the matrix of the compact AV node. And this may provide some insights as to why we see these type of changes in patients. So epithelial type sodium channel homology with the virus itself. A second insight has come from severe viral infections of the heart, including with SARS-CoV, of affecting the interstitial cells of Cajal, stretch receptor cells found in some areas of the atrium, especially near the superior vena cava, that may also explain the sinus tachycardia we see in these patients. Dr. Shukla spoke nicely about hydroxychloroquine. Just from a cardiologist, electrophysiologist perspective, we have to remember that hydroxychloroquine is an antiarrhythmic drug, and like any other antiarrhythmic drug, has some proarrhythmic effects as well. Primarily, its effects on the delayed potassium current and the pacemaker current. The drug is not dissimilar to quinidine and quinine, and in fact, the effects on the lysosomotropic agents are shared by drugs like quinidine that electrophysiologists are more commonly known to use. The big difference is the half-life. So once you do start seeing issues of proarrhythmia, can be generally more of a problem with hydroxychloroquine than its closely related drugs. Word about arrhythmia and COVID-19 is the mix with hypoxia, ARDS related arrhythmias. Hypoxia has its own direct arrhythmogenic properties. And the most important ones that we have to think about are sinus tachycardias, atrial tachycardias, and hypoxia-related PVCs. The clue will be bursts of PVCs of multiple morphologies. That's unusual to be from myocarditis because it does not spread that quickly, but hypoxia itself, when that's the problem, we might see that kind of problem. Most of you are aware, mimic of atrial fibrillation, multifocal atrial tachycardia, well known to occur in the course of severe ARDS. Polymorphic VT, typical with hypoxia, PVC, 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 coupling of the PVCs, and then getting into ventricular fibrillation. The hypoxia has to be fixed, otherwise no antiarrhythmic drug is going to be able to help in that situation. Described now is this inappropriate sinus tachycardia lasting after the recovery in the rehabilitation phase and beyond, probably a result of severe catecholamine stress, the same type of stress that also produces outflow tract tachycardias seen in some patients with SARS-CoV myocarditis. The mechanism for this and the sinus tachycardia is probably because of this very severe stress that the patients are at that time and may not be related to inflammation. Other clues is this ectopic tachycardias are in some unusual sites, like from the annular region where we have innervation. So innervation sites, like along the annulus, atrial fibrillation, ventricular ectopy, may be things related to dysautonomia being part of the stress, excessive stress response in these patients. To summarize, malignant arrhythmias is what we focus on these patients. The worse the heart is affected, the more cardiac injury is present, the more likely we are to see these arrhythmias. However, some very specific arrhythmias we don't see in the run-of-the-mill severe myocarditis includes high-grade AV block, sinus tachycardia, and inappropriate sinus tachycardia. So brief summary with some insights into why this disease may present with a unique spectrum of arrhythmias. Thank you very much for your attention.
Thank you so much, Dr. Asiratham. That was excellent again. I have attended so many of your lectures over the years. A very good insight of electrophysiologic effects of the COVID-19.
Thank you.
While we are preparing for other questions, I really want to ask your insight about because I've been seeing a surge of patients who actually gotten recovered from COVID-19 in March or April. Now they're presenting with the incessant inappropriate sinus tachycardia, especially young female. Obviously, conventional measures like beta blockers or calcium channel blocker is either not well tolerated or they are ineffective. What is your take on a Corleone therapy for those kind of patients?
Yes, so I think when you see severe inappropriate sinus tachycardia soon after a critical illness, it could be one of two things, just the syndrome of critical illness and inappropriate sinus tachycardia. And that's very self-limiting. Typically 3 to 4 months gets better, or direct effects of autonomic neural effects of the infectious or inflammatory process, which will not get better. And I think a simple test that can be done is the pseudomotor reflex testing. in these patients. If the pseudomotor reflex testing is normal, I think reassurance, controlling the rates is enough. If it's abnormal, this is a bigger problem and may require sinus node modification or some autonomic type modification with an epicardial approach. Ivabradine definitely can be tried, but generally speaking, it's really supportive, improving volume status, fluids, stockings, and just encouraging the patient that things will get better. If really it's the rate itself that's producing a problem, like maybe some myocardial dysfunction, ivabradine is probably a better choice than a run-of-the-mill beta blocker.
Thank you. And then I'll open up the audience for the for Dr. Bharat and Dr. Asivatham.
Dr. Bhimaraj has a question, I think, for Dr. Bharat, but I have a question for Dr. Ashirvadam while he comes on. What's your experience with hydroxychloroquine in Mayo Clinic Hospital? And especially if you're having arrhythmias, what was your experience with using amiodarone in these patients?
So the only patients with hydroxychloroquine in Rochester were patients who were started elsewhere and then transferred. So it's not part of our one of our studies here. But the key is to look at the QT interval. It can be very difficult with the tachycardia, superadded repolarization changes from hypoxia. But that's the key. The drug is generally stopped. And if torsade occurs, because of the half-life that you have with hydroxychloroquine, it has to be a lot of supportive measure, so cardiopulmonary support to try to get them through it. If the patient has a lot of atrial ectopy, then smoothing out their atrial rate with atrial pacing a little bit faster than their sinus tachycardia might help. It's important that we should not try to normalize the rate with ventricular pacing because there will be a paradoxical worsening of the dispersion of repolarization. Amiodarone will not make it any better or worse in the short term because the potassium channel effects of amiodarone take several weeks before they can occur. By that time, you have enough beta blocker from amiodarone, so there won't be any increased risk for torsade. It won't be a treatment, but it's unlikely to be an increased risk for torsade. So amiodarone would be used because there's also monomorphic VT, maybe from the myocarditis or a stress-related Takotsubo, something like that.
All right, well, we can ask question whole night, but we have another webinar scheduled and the speakers are ready. So unfortunately, I have to wrap it up. And thank you very much for all the speakers. Thank you very much for all the panelists and all the audience. Thank you for joining. And we hopefully will be having successful webinar in the future. And thanks to President Dr. Suresh Reddy.
Thank you, Gunjan. Thank you for wonderful speakers. So thank you for joining today. And we really appreciate all your input and thank you again. And the next speakers are here. And Dr. Lingisetti, are you here? It's all yours. He's from Arkansas and they are going to share their experience from the southwest corner of the country. Thank you.
I think I can.
Dr. Lingisetti, you're here?
Yes.
Yeah, please take over.
Thank you.